My name is Raj Manoogian. Thanks for the opportunity to be here and speak with you today. I'm an orthopedic surgeon in Mount Dora, Florida, and I thought we'd talk today a little bit about total joint replacement surgery. Every day I have a lot of questions about joint replacements and your different options, and there's a lot of new information out there that you hear something every day about something new or something better. I'm sure the advertisements and all the ads, and I spend a lot of time every day, sometimes hours, talking about all the new information. So I said, you know, maybe I should just give a little talk about it. Maybe better that way, but I'm always happy to do that. I think you know, talking about all the new things that are out there and the different things is very important to talk about some of the facts and some of the myths and things like that. I trained in York, Pennsylvania. I had the opportunity to work with Dr. Townley, who is one of the founding fathers of joint replacement surgery in America. He created one of the first total knees, and also he was responsible for production of a total hip, the design and production of a total hip some 30 years ago. And I spent a year with him after studying total joints, and I also have studied an extra year of spine surgery, and I'm trained in, I was a resident trained in orthopedic surgery. First, what I'd like to talk a little bit about is total joints in general. You know, what are the important things when it comes to a total joint? And the things that I think are the three most important things with total joints are these three things. A total joint is a mechanical device that a lot of pressure and weight goes through. So one of the most important things about total joint surgery is that when the prosthesis is put into the body, that it be put in the proper alignment and rotation. This is the most important thing. And the reason that that is so important, and the way the example that I always give is a car tire. If you have a tire that's not aligned properly, where the weight's being distributed through a certain part of the tire and not all of it equally, that tire can wear out in a very short period. 4,000 or 5,000 miles, you have no treads left on the tire. But if the tire is properly aligned, then the tire could last up to 65,000 miles. So the proper placement of the joint in the body, where it's distributing the weight through that joint in the proper fashion, is one of the most important things about total joint surgery. It's not something you hear advertised on TV. It's not something you see in the newspaper. It's not something that a company will tell you about the prostheses. But it's the most important thing, yet it's something we hear the least about usually. Now, that's the first thing that's the most important thing. The second thing that's very important is that after you have the prostheses, you know, the avoidance of complications is very important. Because even if you do an outstanding surgery and you have an excellent placement, but you develop a complication after surgery, that makes the results very difficult, you know, for the patient. So the avoidance of complications, whether it be an infection or a blood clot, dislocation or loosening of the prostheses, fractures, things like this. An avoidance of a complication is the second most important thing, because no matter how well the joint has been put in or how excellent of a joint it is that you had put in, if you have a complication, that nullifies those things. And you have to make corrections to make that problem better. So that is, in my opinion, and of course everything I'm saying up here is my opinion, but you know, that is the second most important thing when it comes to total joint replacement surgery. And then the third important thing is the prostheses. You know, the prosthetic that is put into the person. You want a good prosthesis that has a good track record and, you know, has safety and all the other things associated with it. Now, with that being said, you notice I put that, you know, that is out of the, you know, important things. They're all very important. There are other important things that we're not talking about today, because I could be here for days talking about it. As some of you probably know that are my patients. But I place that as the third most important thing in my talk today. Why? Because many of the prostheses there's a lot of standardization that's happened with prosthetics, and they have all become very good or very good and excellent. I do believe there are differences in prostheses still today, but it's the third most important thing, I think, and let's talk about why that is. When a surgeon puts in a prosthesis, his ability to put it in has, there's something we call, a learning curve or different things like that, or your training. And when my patient says, well, what prostheses do you think my surgeon should put in me? And my answer is always the same. The one that he's most comfortable putting in and can do it well. For example, there's a total knee that I happen to use. It's called the rotating platform total knee. It bends and rotates. I trained putting in that knee. I used it in practice. I've probably been putting them in for 15 years and maybe closer to 20, including my residency. But it's the one I use, and I like it, and there's a lot of reasons I like it, which we'll talk about today. But I have a lot of experience with it, and I can put it in consistently with predictable results. Now, if someone's never done that knee, because it is different, the way you put that knee in is a little different than how you put the other ones in. It may be a great knee, but I wouldn't recommend someone necessarily do that surgery if they haven't done it or if it's not what they've trained to do. So the prosthetic is very important, but I think of all the three factors is the third most important. So these are the most important things about a prosthesis. And why are these three things important? When we do a surgery for prosthetic replacement, our goal is to give a good long-term result. And that number, with the years, has been getting higher and higher. 5 years, 10 years. When I first started, they said, well, we can predict that you'll have a good 10-year result. 15 years, and now, the numbers we look for is a 20 or better year result. So when I approach my patient and with the thought of helping them with a total joint, my idea is that my goal is that we're able to provide them with a prosthesis that's going to give them a 20-plus year result, or predictable survivability of the joint for 20 years. And those three things that we talked about are the three most important things when it comes to long-term survivorship of a total joint. Those three things. Now, there's other things we hear about a lot. For example, let's talk about one of them, just right off the bat. Minimally invasive surgery. How many people have heard that term? Raise your hand. How many people have heard that term advertised? Raise your hand. Mm-hmm. I have many times, usually every day a little bit. We don't hear as much about it today as you did 5 years ago. But minimally invasive surgery is talking about the approach to putting in a total joint. There's different ways to put them in. We call it the approach. How do you make the incision? How do you split the muscle? What do you do to put the prosthesis in? And how do you close the skin? All these things. It's the approach to a total joint. Now, the reason I don't mention it in my most important things of a total joint is because the long-term survivorship of a total joint, the 20-plus year survivorship, has nothing to do with that. Is it a good thing? Yes. Is it a bad thing? Not necessarily, but it has nothing to do with how a patient does long-term, the most important thing. There's a lot of good things we learned with minimally invasive surgery, and there's some important things we learned that can be a problem with those type of surgeries. So but it's not something that has a effect on the long-term survivability of a joint. That's very important. And that's something that again, when you hear an advertisement about it, they don't talk about how that impacts the long-term survivability of a joint. Now, we can talk about that a little bit more later, but for right now, we'll leave it at that. Yes, sir. The advantage of the minimally invasive surgery, or the hoped advantage, is a quicker recovery with less pain. So. In some cases, the minimally invasive surgery can provide a quicker recovery, but I think the amount of time the difference in the amount of times that we're talking about are weeks. versus, a several week difference, weeks versus, maybe 6 weeks versus 10 weeks. So the recovery time may be a little shorter by 4 weeks. But since you brought it up, we'll talk about it a little bit. The proposed advantages of the minimally invasive surgery really never bore out in clinical practice. For the injury for total hips, on the minimally invasive surgery, the injury rates, for nerve injury or fractures during surgery, or the placement of the prostheses and the proper alignment was more difficult through the smaller approach surgeries. And remember, the things that we said are the most important things is placement of the prostheses, avoidance of complications, and the prosthetic. So if you're doing something that makes doing those first three things more difficult, and in the clinical field, if those things are not consistently being done better with that approach, then we have to ask ourselves, are we doing something that's making the long-term results better for the patient, or is what we're doing, can it make it more difficult to get those long-term? Now, a lot of that depends on when the surgery is done and who, as we say, in whose hands it's done in. Some people that do the minimally invasive surgery are very comfortable with it, and those three things are not affected by it, and sometimes it can be more difficult. So the proposed advantages did not bear out in our clinical review of the cases. When everyone was looked at that had it this way versus that way, the advantages didn't outweigh the disadvantages, and there's less of it being done now. But there's a lot of positive things about it. Every time we do something new or different, you can always learn and take the positive things from it and learn what works or what doesn't work. Now, my policy has been, I wait until it's all bore out, until we have a 5-year look at something. Generally, not always, but generally, how does the 5-year results look? And then if they're good, then proceed forward with that. But so there are some, advantages with the recovery, but those advantages, again, will not impact the long-term survivability or how the patient does. But that's an excellent question. Right, total joints are so important, and it's so important that you do those three things right. You never want to do anything that compromises those three things first. If you can do it and not compromise those three things, then you're okay. But you have to always ask yourself, or you always check the facts, to make sure that what you're doing is not compromising those three things. I think that's a good litmus test of whether or not something, that's good or that's good for the patient or not. So now we're going to talk about the hip surgeries. I'm going to talk a little bit about total hips and what we do with the hips, and there's different, and this is a little bit to do with the third thing, the design of a prosthesis. But the bone, I just brought a model here. The bone in the human body, all of us, the bone that we have, the main thing that tells us about how a bone reacts with its external environment is called Wolff's Law. And Wolff's Law states that when you stress a bone, it reacts to it by making more bone. Or if you shield the bone from stress, the bone can slowly decrease its mineralization and you can lose bone. And you've all heard the saying, use it or lose it. Well, the bone in our body, all human beings and mammals, the bones are subjected to external stresses, what we call an outside-in force. Now, I had the good fortune of working, again, I mentioned it once, I'm going to say it again, and I'd probably say it 10 times a day. I had the good fortune of working with Dr. Townley, that I did my joint fellowship with, who talked a lot about bone and how it reacts to stress and how that has something to do with the design of a prosthesis, or how it should have something to do with design of prosthetics when it comes to bone. And his idea was that what we have, or what God gave us, is close to perfect, and our job is to try to emulate that. If you want to know how to do it, just look at what we already have. And if you get close to that, you're getting close to the right thing. As we get away from that, then the results change accordingly. But so he talked a lot about the bone and Wolff's Law. And with hips, I think it's particularly important because of there are some differences in design of the hips. So there's the living hip. Dr. Townley taught me several things. That's one of them. Make sure that the prosthesis does to the bone what is normally done so you don't lose your bone. Because we're doing prosthetics now in patients, and the longevity of all of our patients, and myself one day I hope, is going higher. I have patients that we used to do prostheses in their 60s, and then it was 70s, and then it was 80s, and now we have patients that are in their 90s that are otherwise excellent, healthy, of sound mind, active, and they have a bad joint and they need a surgery, and nothing else has helped them. And mind you, with that being said, I want to say one thing: a total joint should always be the absolute, last option that we use. You should exhaust all other possibilities first, and you should try to buy time. And when you do, when you've exhausted all the possibilities and now you're having a difficult time maintaining your quality of life, then a total joint becomes a good option. Now, why do I say if you can exhaust the other possibilities? Because our longevity has gone up so immensely, 90s, and I even have patients that we've done surgery on that have broken their hip. My oldest patient was 103 years old, and we had to do a open reduction, internal fixation. We had to fix his hip, and he did good for years after that. I saw him until he was 106. But because patients' longevity is getting more and more and more, these prostheses have a certain lifespan. Even though they're a lot better, we're getting 20 plus years. We want to make it the last option, so we've bought as much time as we can, so when we do one, hopefully it's the last surgery that the patient needs. So that's another important point about joints that I want to talk about today. It should be, a last option, or an option that you employ when the other things don't work, as far as that goes. Now, with the hips, Dr. Townley taught me several things, one being Wolff's Law. The second thing is he taught me always think for yourself. The good Lord has given us a gift, several gifts, but one of them is our mind. And He's given it to us for a reason. He wants us to use it. He wants us to think for ourselves, and He wants us to learn and then question and ask and then do according to that. The reliance on your mind. He always taught me that of course the most important thing was that learn as much as you can and then make a determination for yourself on what you think is the right thing. Don't assume things, because by assuming we keep doing the same things over and over and over. And the thing that I always said about Dr. Townley was he was the person at the times, if you can imagine, the whole world, the universe thought that the earth was flat. And who thought that? Everyone. The professors, the teachers. And it was taught for years by the smartest people in the world. Of course, back then there were geniuses as well. The geniuses of the time thought that the world was flat. But it took someone who thought about it, who used the gift, and said, no, the world's not flat, it's round. Now he said, geez, Dr. Townley was that person in orthopedics who said, the world's not flat, it's round. In orthopedics, he changed a lot of ideas and thoughts to this day we're still learning about. But I used the most important thing he taught me. He said, think for yourself, and if you can make something better, do it. And Dr. Townley had designed a hip that was what we call a platform prosthesis that we're going to see right now. And we changed the design to make it better. So I did what Dr. Townley taught me and made his design better. And that's called the living hip that we're going to talk about today a little bit. This is the prosthesis that we employ. It's the living hip. You see, it's a short prosthesis, but if you look here, there's a collar on this prosthesis. And this collar, the thing that makes it different than a lot of collared prostheses is that it has a collar medially on the inside. It also has a collar anteriorly and posteriorly. And this collar rests when we do a total hip prosthesis and we take the ball off. Now remember, we said all bone responds to stress. So when you walk, all your body's weight goes through the ball, through the hip into the femur. That's what the body knows, and that's how the bone stays strong. So when we cut the ball off and we put a prosthesis where that ball used to be, that prosthesis is either recreating the stress that used to go through that hip, or it is not, or it's somewhere between. How close is it to recreating the stress that went through the hip before you took the ball off? If it's very close to it, you're going to keep all the bone. If it's very far from it, you're going to lose the bone. And I'm going to show why now. So this prosthesis has a collar, but it's short because what we learned was that this prosthesis relies on this collar and this coating here. That's where it stresses the bone. That's where the bone grows into it. And once it does, the stem is insignificant. The length of the stem is insignificant. And that's what we did. We made it extremely short. And the reason we did that is patients after a total hip, when the bone, believe it or not, just like plastic bends, wood bends, bone bends too. We call it the elasticity of that material. When you walk, the bone has a little bit of a bend to it every time you take a step. And when you have a prosthesis that goes into the canal, for some patients that causes pain, and we call it thigh pain, around the stem, because the bone's bending, but the stem doesn't bend. And that can cause, in some cases, severe pain. But the only way you can treat that pain is to take the prostheses out and then cement in the prostheses where there's no motion around the prostheses. And what I found was with my patients that had the thigh pain, when I would present them with that option, I said, well, everything looks good except you're having thigh pain because you're one of the small percentage of patients, or the percentage of patients that will have thigh pain when you have a prosthesis in the canal. And they said, well, what can I do? I said, well, we can take it all out and cement another one in. They said, forget it. I'll keep the thigh pain. So, and we thought, in thinking about that, we said, well, if the stem in this case is not really helping us, let's do something about it. And what we did was we changed the dimension of the prosthesis so the patients won't have that pain anymore. And by doing that, what we found was we shifted even more weight to the top where the ball came off, and they made more bone quicker. And that's the thing that we've seen, is that patients after the prosthesis can actually make bone and not lose bone, which you won't see bone formation in other prosthetics. You see bone loss, you see a lot of bone loss, or you see a little bit of bone loss, but you won't see bone formation. But that's what the prosthesis do. And I'm going to try to show why right now. Ultra short femoral stem. It's got a full anterior, medial, and posterior collar. It's a proximally loading prosthesis, so it puts the load proximally in the femur. I brought a model today to show you that. The ultra short stem, it helps reduce the incidence of thigh pain. The stem does not extend into or beyond the natural anterior bow of the femur. This allows for increased proximal fill with the resultant increased stability proximally. Now I love this picture because this is going to talk a little bit. This is going to show you a little bit about what we're talking about. This is a hip, and these lines here are all the stresses that naturally go through the hip. There's the forces that go right down here. This is when you walk, your weight goes right through the hip right here, from the top of the head all the way down into the calcar region here. And if you look at an x-ray, you actually see all these lines. These are torsional lines, stress, bending forces, and then compressive forces. So the prostheses, now if you take a prosthesis, and let me exaggerate a little bit, and we put it right in here, from here down, and I just really feel it in this canal, and then we put no force up here in this bone where the head used to be, what do you think happens to all this bone right here? It slowly demineralizes, and you will lose it. If you look at prostheses that do that, which there have been many, in the beginning what they did is they would drill this canal out and they'd put in a big prosthesis about this big, fully porous coated, that would be stuck in the canal. But there'd be no force going through the proximal femur, and what they showed was that if you looked at the x-rays 5, 10, 15 years later, every few years you'd lose a little bit of bone. At the time they said, well, it doesn't matter because by the time you lose enough bone, it won't matter. It takes years to lose enough bone until that thing will loosen up. But what we talked about before is the longevity of patients has really gone up. It's not a day I don't see patients in my office 95, 96, 91, So it does become important, and those years do matter. So what Dr. Townley, again, fourth time I'm mentioning his name, he taught me is he said, look, we have two eyes, and we can see out of one, but should we pull one out just because we have two? Of course not. If there's something we can do to save the bone because you don't know when you're going to need it. Why lose bone or take away bone that you could keep? Sure, it works if you do take it away. Sure, you can put it in the canal and it'll last for 15 years with no problems. But what if the patient lives 10 years beyond that? Then what? Well, then what happens is you don't have the bone, the prosthesis loosens, you fall, you break, and now you have a revision situation, and you don't have the bone there to work with to do something that's going to work well for the patient for the next 10 years. You've lost the opportunity or the bone that you need. So our goal is to always do what? Stay as close to nature as we can, do what it does normally, and this will, help. This will help preserve the bone for a longer period of time. What does this picture do? This picture tells us if you were going to build a house, if you were going to put all the weight of a house here, how would you put it? Would you cut an angle here and then build it on a slope? Because here's the forces. If these are all the forces, would you cut it backwards? Would you cut it that? Or would you cut a perpendicular angle here and then put the house on top of that in a perpendicular fashion? I would cut a perpendicular angle here and then put all the weight of the house on top of that, because there'll be no shear force for that prosthesis. It will instantly create a situation which that prosthesis is inherently stable. Inherently stable when you do that, because when the patient puts weight on the femur, what does it do? When they put weight on their hip, it pushes the prosthesis down. And now, with that being said, it's actually the angle that you're cutting is perpendicular to these compressive forces, but it's not perpendicular to the axis of the stem. And I'll explain why that's important here in a second. And I'll try to make that clear. The reason is if that was exactly perpendicular to this axis, when a patient was sitting and they go to get up, it could spin it. But because it's off 15 to 20 degrees off this axis, what happens is when a patient goes to stand up and it puts weight on that collar, it pushes it down. And the only way that prosthesis could spin, because it's a little bit off the perpendicular, because it goes all the way around and it's sitting flat on that bone, the only way you can make it turn or spin is you'd have to pull it out of the canal in order to allow it to spin, because the collar stops it from spinning. So the collar is perpendicular to the forces, but just off the axis. Now that's important because one of the most important things in hips we find out later is that what we call torsional stability, or its ability to resist spin. In this prosthesis, because of the design, it intrinsically has something in it that makes it stable, where if you were to get up out of a chair or walk or put all your weight on it, it's intrinsically stable from the beginning. That allows the bone to grow into the prosthesis. Because if there's motion in the interface between that prosthesis and the bone has a harder time growing in, because bone has to grow in with it being still. Ones that are unstable, or if you have a prosthesis that's not intrinsically stable, it has more tendency to do that, more tendency to move. And when it does that, instead of the bone growing in, fibrous tissue will grow in around it. And what happens when you have what we call fibrous ingrowth? What happens is the prosthesis becomes loose, and you have a painful prosthesis. And then it has to come out and you have to redo it. With the design of a full collar, because the prosthesis is intrinsically more stable from the beginning, you have less chance of that happening. Can it happen? Yes, it can still happen. But the chance of it happening is much less. Now, if you have a prosthesis that does not have a full collar, and there's a difference, because a lot of prostheses had collars, but it was only on the medial side, only on that medial lip, and those could still spin because you didn't have enough flat surface to stop the spin. But if you have a prosthesis that has no collar, you have to really make sure you push that, fit it in the canal as tight as you can, because if you don't, it's going to spin and you're going to have a loose prosthesis. Can you fit one in tightly that works? Well, yes, you can, and they can work very well, but because the design is a little different than what you started off with when you took the head off, they can work well, and they can work well for years. But my opinion is, in the long term, they're going to work well for years, but you're still going to lose a little bone. But if you reproduce the forces that you had in the hip naturally from the beginning, you're not going to lose the bone. And this has been shown over, with these fully collared prostheses. When they first start putting them in Port Huron, Michigan, from 30 years ago, those that are looked at now have the same bone that they did the day they put them in. So the living hip is designed to mimic the natural forces, work with nature, respect nature. To understand the nature of bone, we turn to Wolff's Law. What does Wolff's Law tell us? Wolff's Law tells us that bones adapt structurally to resist the specific forces acting on them. Bone remodeling, affected by mechanical function according to Wolff's Law. Removal of external stresses can lead to significant bone loss. Changes in bone architecture are associated with changes in loading. Now, this was the original, see that long stem version of the prostheses. Now you see you see all that bone right under the collar here? You see that? On these prostheses with no collar, with time what can happen is, see, this is called the lesser trochanter. This is a good judge of how much bone is here and how much you gain or lose or keep. If you look here, this entire medial side of this prosthesis has lost bone, and or there was none there when they put it in. But what happens is you lose more and more bone, and this is the coating. You can see here you have the body's trying to maintain stability here. There's some extra bone being made at the tip here. But this is where you lose the bone. And if you lose enough bone, and I've had cases where they had these fully coated prostheses where they're stuck in the canal here, where they've lost bone to here, and when they fracture, there's nothing left to work with here. But this prosthesis, you can see the bone there. The living hip utilizes the same platform design as the BioPro PSL hip stem pictured here. And here's a version of it. If you look at this here, you can see that this collar that goes all the way around is at a perpendicular force here. And of course this here, it's off this. So for this to spin, if you can imagine bone all the way under here, you can't spin that unless you were to lift the collar out of the stem. You'd have to lift it out of the femur before it could spin. But when you walk, what happens? You push it back down in the femur. So actually the thing that can make it unstable in this hip makes it more stable. When you walk or get up from the chair, you're actually pushing it down harder, making it harder for it to move. That's the beauty of it. That's the important thing. And I hope that these pictures help demonstrate that. The collar is perpendicular to the major stress forces, not the axis of the stem. In order for the prosthesis to rotate, the stem would have to be pulled out of the femur. During weight bearing, the prosthesis is pushed into the femur. Since the stem is ultra short, it's never in the isthmus, transferring full load to the proximal femur, as if the femoral head was never removed. Sizes vary, and this is the smaller size, this is the bigger size, because as patients do get bigger, you still need a bigger fill. This allows maximal proximal fill. I don't know, does anyone in the room know this guy? That's Lucky. Everyone knows Lucky. I grabbed this stick because I was trying to demonstrate the quickest way I knew about the femur. This is a stick being put on bend. If you had a prosthesis that went all the way through this stick and then you bend the stick, what's going to happen? It's going to hurt. Well, that's what happens with the femur. That's why you have thigh pain. So doing what I was taught, thinking for myself, realizing that if all the stresses are really indeed proximal with the prostheses, why even be in here with the stem? It causes pain. If you get stuck in the canal, which the other which is the goal of many prostheses, is to get it stuck in the canal, then you're taking the weight away from the femur proximally. And if that happens, the prostheses will function like all the other ones, and you will slowly lose bone even under the collar, because the collar is being held up, the force isn't being put through. So we got rid of the long stem and made it work even better. And here's a picture right here. Now you can see all the bone under the collar here, and what I'm going to do, I'm going to go through a bunch of these. But this is where the bow is. The stem is well above the bone, and this part of the femur, if you can imagine, if you have a long bone and if you have a bending force, most of the bending is going to happen here, not in the very proximal and distal ends of the bone. So because the stem's not in the canal, it avoids the pain in the hip and the femur. The tip of the stem is just under the lesser trochanter as opposed to down here. Of course, all the forces are here, And if you look at the x-rays year after year after the year, this is where we make our cut. You see how much, this is where we make our cut for this prosthesis. Many prostheses, the cut is made like this. And the prosthesis is jammed in the canal and fit. Of course, if you have a nice fit and you make it really tight, it works really well. But you're not reproducing the force, and some bone loss will occur. And in patients that live for a long time, that becomes very important. Who's this hip for? Everybody was my answer. Here's a picture. Now I like this picture. You see, this is really fit in here very well. Even though this is a short stem on the lateral, we call something called 3-point fixation. This is a little bit technical, but there's 3 points at which this hip is still fixed within the canal, although it's in a short distance that won't cause thigh pain. These are just some pictures of the prostheses. This is a beautiful picture of the bone underneath the collar. You can see that bone will be maintained. Really, what we also have seen is with the prostheses year after year, when we look at this here, sometimes we actually, because it's being stressed so wonderfully, the bone actually builds up under the collar where you're making more bone. That's why I call it the bone making machine, or the living hip, because living meaning it's close to what nature intended. 1.5 years post-op, not a millimeter of bone loss, great bone quality, no loosening, maintenance of normal bone architecture. Because remember, Wolff's Law stated that if you keep the forces the same, you're going to keep the architecture the same. Or the bone actually reacts to stress. If you stress it, you make more bone. We know that, and we're taught it every day. Walk so you don't get osteoporosis and all these things. So why shouldn't the prostheses that we use also respect those laws? Well, there's a lot of reasons why. There's a lot of reasons they don't respect Wolff's Law, which we can talk about here in just a little bit. So what is this? These are picture after picture after picture of patients that had the prostheses, and then one thing that you'll notice about all of them is the bone. No bone loss. And then we got a bunch in here, and there's a bunch more, but I'm going to kind of go through all these. See that? These are all different patients, all for different reasons. Now, this is a hip that we had to take out because the patient, this was not a total hip. This was for a fracture, where you can sometimes do just the ball. It's called a hemiarthroplasty, or half a hip. This patient ended up getting an infection, and the prostheses had to come out. It was a very short time after the prostheses. Now, remember what I said? The important things, avoiding of complications. When one of these have to come out, a lot of things change. But the reason I kept this is when I extracted this prostheses, it was in a very short time after the surgery, about 6 weeks, I believe. But the thing that I was so impressed with was I could barely get it out because the bone had done what? The bone had already, all this is bone, the bone had already grown into the prostheses in such a short time. Why? Because the prostheses really stresses the bone in such a fashion that the bone responds to that by doing what? Healing into it and making more bone. But that's why I saved that picture. And our final picture is this. You have the whole world in your hands. No, just kidding. That's a little bit about the hips. So I brought a model that I'm going to just show here just for a second. This prosthesis has no collar. We cut the bone off at this non-perpendicular angle to the force. It fits in here, and it's good. It's a good prosthesis. Don't misunderstand me. These prostheses are all very good right now. But I think if you had a choice of having something that saves the most bone, where you cut the bone up here at an angle that will emulate what we have normally, which would you choose? That's the question. I'd choose this one. Oh, I'd like to talk about one thing, about what you said, sir, about the question about minimally invasive surgery a little bit. I think there's a lot we can learn, and we're going to always get better at what we do, hopefully. That's one of the things. There's all sorts of approaches to the hip, and we hear a lot about one now called the anterior approach, where you spare the most muscle with that approach. I've changed my approach a little bit to spare, spare less muscle, to split the fibers instead of cutting across them and peeling them and then letting them come back on the bone. We've learned a few things about that. In the beginning they did great, then we had some cases where we had some pain associated with the change that we've made better. So there's always things you can do hopefully to make things better and better. But the most important thing still, even with the hips, is the first three things we talked about. Putting in the prostheses properly. For example, the cup. The cups are very standard, by the way. A cup is a cup is a cup. But the stems are different. But for example, when you put in prostheses, if the cup's put in like this, in what we call a vertical orientation, what happens? This hip can dislocate more easily. Or if it's put in anteverted or retroverted, it can dislocate. So when it comes to a hip, again, like the knees and everything else, the orientation of the prostheses to maintain the stability and avoid dislocations, and or if you have a prosthesis where if you have a cup put in like this, you're going to really put a lot of load just on this rim and you're going to wear that plastic away quicker. So the most important thing still is not the approach, even in hips. And if someone says, well, should I have an anterior, posterior, lateral? Those are the three approaches, anterior, posterior, lateral, or variations of all of those. I say you should have the one your surgeon does well. That's the one you should have, because that's the one that's going to give you a good long-term result. But what we see and hear a lot every day is patients say, well, I heard that there's a new thing. You can get up and golf the next day, anterior hip approach. Sure, you can get up and golf the next day, but the thing might fall loose in 3 years. I'm exaggerating a little bit, but if you can get up and golf the next day and you have an excellent prosthesis and a good positioning and a minimal complication rate, then that's great. So, for example, I do think there's some, the anterior approach, there's a lot of merit to it because there's a lot of wonderful things about that approach. And that's, and we've are incorporating that slowly into what we do, because if you can do it safely and still maintain the other three important things, then it can be a wonderful thing. So, there are a lot of things that when it comes to the approaches that are important, but it's not the most important thing. That's one of the things that I wanted to talk about today, to emphasize and stress when it comes to total joints, what's important. Because it's nothing you're going to hear advertised or you're going to really read about right now in the general media. And I just think it's important for us to talk about it and for patients to understand that, because the consequences are very important long term. So those are hips. Any questions, please?
I have a question.
Oh, she said if you have a situation where you have an X-ray that shows bone-on-bone arthritis, but the patient has good motion and is otherwise doing fairly well except for some pain that's controlled with Tylenol, what do you do? But that's a terrible X-ray and it's bone on bone, and I see a lot of those. What do you do? And this is my answer. When we take care of a patient, we do surgery. I always tell my patients, I'm taking care of my patient. I'm treating my patient, not the X-ray. So a lot of our patients have bone-on-bone arthritis, but they can function very well with that. And my advice to them is, when you can function well, you leave it alone. Don't do the surgery. Sometimes. And what do you do? Well, if Tylenol works, then that's great, but a lot of times it doesn't. And when it doesn't, and you can't do the things and other things don't help you, then the surgery is a good option. So, so that's a great question, because often, we look at it, often, you can have, there's, often the options, we lose sight of all the options that are available. And I know what every orthopedic surgeon in the world would do. They would never have the surgery if it was their knee. So that's my answer. If you have a knee that's still working well, even if the X-rays are bad, I would say avoid the surgery. Next question, please. The question was talk a little bit about dislocations in total hips. It's one of the complications, and this is something I didn't, even when we do everything what we consider 100% perfect, right, 100% right, you can have complications such as dislocations, infections, bleeding problems, tendon, nerve, or vessel injury, things like that. Dislocations being one of the main things with total hips. Dislocations in the beginning, when we first did the surgery, the prosthesis being a mechanical device and a little different than what we have, and having interrupted a lot of the tissues around the hip, it can be more unstable immediately after surgery, so we have precautions. Don't cross your legs, don't turn your knee in or out too much past a certain point, and don't flex your hip beyond 90 degrees. If you violate those precautions, you can dislocate a hip in any circumstance. There's no mechanical device, a hip, that you can't dislocate. So our goal is to maximize the position of the prostheses to make it very hard for a patient to dislocate that hip, even if they go beyond the things that you should do. So I try to, those are our goals. But that's what a hip can dislocate. I've had patients, for example, sit in a chair, and I had one gentleman, he was 4 years after his surgery. He saw a piece of lint under the chair, so he bent all the way down, his chest hitting his knees to get the lint, and he dislocated his hip, even 4 years later. But often, fortunately, we have one of the precautions is don't cross your legs, because that externally rotates the hip to the point where it can dislocate. But there's probably not a day in the office where I don't have a patient who's had a total hip when I walk in, their legs, they have their legs crossed. I said, hey, you're not supposed to do that. But they said, oh, sorry, doc, I forgot. So knowing that, I always try to, we do our best to put the prostheses in a position that maximizes the coverage of the head, making a dislocation difficult. Now, we've had some neat things develop recently, and I've heard some controversy on whether it really is what it's making it not dislocate, but we use bigger heads that they're harder to dislocate, and other things like that. But that's an important part of total hips dislocation. So we try hard to prevent it, but it's not always preventable. Yeah, that's a good question, sir. BioPro is the name of the company that manufactures the prostheses. Now, on the total hips, sir, my preference is to use on the cup side a metal cup with a plastic liner, and then when we can, we use a ceramic ball for the ball. So there are different options for surfaces. For example, I'll talk about 3 quick ones. The traditional one is the plastic with metal, or you can use the plastic with the ceramic. Then you have the ceramic on ceramic, or you have the metal on metal. They all have some advantages and disadvantages. We could talk, and there you could write volumes about it. But I'll give you my rationale of using the one we do, why we use the particular model. When you have a metal on metal or a ceramic on ceramic, it's what we call a hard on hard surface. So there's no real cushion between the interfaces, and that can, in some instances, cause some problems. And once you have a ceramic on ceramic or metal on metal, you can't do anything else but that in the future, because those wear particles are available. And if you put a plastic liner in later, you'll wear that out. So I don't like the fact that I have no other options later except sticking to the same wear. So the metal and the ceramics have gotten so good, and the plastics have gotten so good, that even 20 years ago when they were doing the hips, or 30 years ago, the technology then, many of those hips lasted 20 plus years. Dr. Charnley, for example, who did we could talk about that. Again, there's so many different subjects, but he did the traditional metal with plastic, and many of those hips lasted 20 plus years. Those things being even better now, I have personally, not switched to either a metal on metal or a ceramic on ceramic surface, because the longevity of what we're using is excellent, and you have it's not a hard on hard surface, and that affords you to do different things. It has advantages. So that's personally the one I have used, but the other surfaces are excellent, but it's just not my preference. Right. The General Hospital states for total joints are between 3 and 5 days, the average being 4 for our patients. And you have 2 options. You can go home at the 4th day with home health, home PT. And for my patients with total hips, I like to just teach them the instructions and precautions and how to walk, or you can go to one of the local rehabs where for 2 weeks you get all your PT dressing changes and everything there. At 2 weeks, I see all my patients back in the office and inspect that patient myself, and then we take the staples out at that time and then do outpatient therapy thereafter. Now for my hips, at that point we just our main exercise for the patient is to walk, and that's it for 4 weeks. Just to walk and bare weight is tolerated, or 50% with their walker, until I see them at 6 weeks, and at 6 weeks we get an x-ray. If everything looks good, then we start the strengthening, and the reason is because of what you talked about, sir, the approach. There's advantages and disadvantages of each, but with my approach I have to wait the 4 weeks for the tendon to be healed enough to really progress them, although we've changed what we do to the point where we've really bumped that up now. But we'll give a quick example. For example, you can have a posterior approach, which is an excellent approach for a lot of reasons. One, you can get up and walk right away, and you don't have to worry about those tendons healing. But posterior approach surgeries have a little higher dislocation rate, a little bit. But when done properly, it can still be minuscule and excellent, okay? But it's a little bit more. A lateral approach, or anterolateral approach that I've always used, has a little longer recovery, but a lower dislocation rate. Generally speaking, again, it depends. There's no absolutes with this. But for me, that was my priority, to have a lower dislocation rate at that time. And then there's the anterior approach, which has the most anterior, true anterior approach, which has a very quick recovery and a very low dislocation rate. But generally speaking, it's 3 to 5 days in the hospital. Staples come out at 2 weeks. You have to be very meticulous during that 2-week period to avoid. But you have to be meticulous in the wound care, and then after that time, you do outpatient therapy for 4 to 6 weeks, or depending on what you've had and how long. No, actually, the prosthesis I use is made out of cobalt chrome, and it has a porous coating. But that's but titanium is an excellent surface. You can use titanium. It's a very biocompatible, and it's a good metal. It's the titanium alloys, but we use a cobalt chrome that works excellent, because then the prosthesis is the structure of the prosthesis is what makes it work. Whatever you use, it's going to work well. If you're relying on ingrowth, sometimes titanium can have a better ingrowth, but in our particular case, we don't use a titanium prosthesis. Well, I really appreciate everyone coming today. I hope the talk was helpful. And if you have any questions, feel free to ask me. Thanks a lot, everybody.